technical difficulty or two, but our technician Whiz over here thinks we got everything going. So let me begin the meeting, and it's my pleasure to welcome all you in person as well as those online to this first meeting of our Georgia House Study Committee on Certification of Need Modernization. And I'm Butch Parrish, and I want to thank Speaker Burns for allowing me to chair this special committee and for appointing members who have clearly been chosen for their subject matter expertise, their legislative knowledge, their real-world experience, and their overall depth and thoughtfulness. Before we introduce the members of the committee, we have a special guest here with us today, and I saw him running around here somewhere, Speaker John Burns. And he's hiding from us over there, but Speaker Burns, we're glad to have you here, and please.
You got my mic teed up, Butch? I know you were having a problem with technology. Good morning. I want to thank you all for being here, and certainly everyone in the audience for being here today. For this gathering, adjacent to the Gold Dome, and to begin this very important work this group has been tasked with. Access to affordable health care is a key component of our quality of life here in Georgia. As the best state in the nation in which to do business for a number of years now, one of our state's key regulatory structures when it comes to health care, of course, are our Certificate of Need laws and regulations. Established when I was a mere child, obviously, in the 1970s, our CON program is intended to achieve three goals: to measure and define need, to control cost, and to guarantee access to health care services for our citizens. In our state of Georgia, the largest state east of the Mississippi with over 11 million residents, that is no easy task. From the mountains of Georgia to the coastal plain, quite a different scenario when it comes to the availability of health care. The number of citizens per square mile, if you will, makes it a challenge. And we know even that has changed much over the last 50 years. Advances in medicine have brought increased specialization, while advances in technology have brought telemedicine opportunities to all of our state. Yet our CON regulations have remained unchanged. That's why the House, through House Resolution 603, established this Study Committee on Certificate of Need Modernization. For me, your charge is simple: to examine Georgia's healthcare landscape and see if our Certificate of Need program needs to be modernized to better meet the healthcare needs of the citizens of this state. Now, I'm honored that some of the House's most experienced and passionate leaders on the issue of healthcare have agreed to be a part of this effort. Chair Lady Sharon Cooper, Chairman Lee Hawkins, Minority Leader Beverly, and several other important members of the House. Dr. Newton, with certainly a specific expertise in health care, Lisa Hagan, who understands rural Georgia, are all part of the panel here today. So I want to thank them for what they will bring to this conversation in advance. But certainly, when it comes to health care and health care policy in Georgia, I know of no more important or knowledgeable person than Chairman Butch Parrish. Butch, if you will, Chairman Parrish, has devoted much of his professional life and his career in public service to improving the health care of the citizens of not only his district, but of this entire state. I'm honored that he, as a member of this House and as a Georgian, that he would agree to lead this important study committee. And I thank my dear friend for his continued service on behalf of our staff and of the people of this state. Thank you, Butch. I also want to thank our private sector members for giving their time and expertise to this effort. We want to thank Ms. Bluestein for being here today as our private sector member. And y'all all know who the members of this committee have been named, and we want to thank all of them, but I especially want to thank you for taking time to be here today with us. This group is a very diverse group that has been assembled of healthcare administrators who are uniquely qualified to help in this work. And I want to go ahead and thank you in advance for your contributions. I want to close by making it very clear, by making a very crystal clear point. What I care about and what I know that what y'all care about on this subject matter is we want to deal with the facts. Facts are pretty important. Facts help us come to the right outcomes, and that's what we're interested in. I want this group to follow the facts and arrive at recommendations which improve access to quality, affordable health care in Georgia. I really don't want you to tell us what you think we want to hear. I want you to tell us what some special interest group may think that you want, that your recommendation should be. We need to know your honest and expert opinion, informed opinion on what will result in better health care for the citizens of this state. It's pretty simple and to the point. And that is the only charge and my only request. I want to thank you all again for your service in the past and for the good work you're going to do in the months before us that are coming to serve this important charge. Representative Cameron, I also appreciate you being here today too, and I did miss that. I just want to tell you again, thank you for being here. Thank you for those in attendance. Thank you for your input as we discuss this most important subject. Good luck, Chairman Parrish. I know you're going to do a great job leading this team, and we just appreciate you and appreciate this team. And I want to thank you all again for your willingness to serve. May God bless all of you. God bless your families, and may God continue to bless this great state of Georgia that we love so much. Thank you, Mr. Chairman, and I appreciate you letting me have the opportunity to speak.
Thank you, Mr. Speaker. Appreciate you taking the time to come by and lay out our roadmap so clear for us. And we appreciate the opportunity to serve, and we look forward to getting back with you as we go down this journey. Thank you.
I know y'all gonna do good work. Thank y'all again. Have a good day.
Okay, now let's go ahead and move forward with our committee meeting this morning. And I think the first thing we should do is introduce our committee members. Before we do that, though, I know we have two legislators, at least in the audience out here, Chairman Darlene Taylor and Mary Margaret Oliver. We're glad to have both of you here. We know that this is a subject that you all are interested in and have been for a long time. Thank you for your interest in being here today. I'm going to ask the members of the committee just to do a little self-introduction, and I'm going to start down here on the right with Ms. Bluestein. And if you would punch the button there so I'll know which one I can turn your mic on for you. Okay.
All right. Good morning, everyone. Cheryl Bluestein, Vice President of Operations at Emory Healthcare. I've worked in healthcare for about 20 years now and have had numerous experiences with Certificate of Need, filling out applications and working through the process. I am very grateful for this opportunity and look forward to contributing. Thank you.
Thank you, Mr. Chairman. I'm Lisa Hagan. I represent House District 156 in South Georgia. We're 6 counties between Macon and Savannah. I have 2 hospitals there that are both very interested in what we're going to be discussing here at this committee meeting today and in future committee meetings and what recommendations we may present to the House. I'm honored to have been appointed to this committee and look forward to learning everything I can about this subject. Thank you.
Yeah. Good morning. I'm Mike Cameron. I represent House District 1 in the Northwest Georgia corner of northwest corner of Georgia. I've spent 32 years in the health insurance industry with Blue Cross in Chattanooga. I worked on a lot of issues with CMS and other industry groups like AHIP and the Blue Cross Association. I bring that experience to the table with me. Thank you.
Good morning, everybody. I'm Sharon Cooper. I represent District 45, which is East Cobb, and I chair the Public Health Committee. I am a long-term member. I chaired the first CON committee when Republicans took over back in 2007, I think, and I'm proud to share and be under Butch's leadership on this one. I am a master's level nurse, and my husband was a family practitioner.
I'm Mark Newton. I represent Columbia County and Augusta, Georgia, District 127. I'm an emergency physician and do some work in urgent care as well. So we've seen the forefront of telemedicine and the costs and the benefits of healthcare and the need for impactful and accessible healthcare across the state. We also are the home of the Medical College of Georgia, which of course trains in 98% of our counties as providers. So we want to make sure that we look at that very carefully, and I look forward to being with y'all.
Dr. Newton. We have a couple of our members online with us, and we're going to recognize them. Scott Rames, can you hear us, Scott?
I sure can.
If you would, just please introduce yourself, and we're glad to have you online with us this morning.
Certainly, and my apologies for not being there in the flesh, but I promise to do so in the future. Scott Raines, President and CEO, Southeast Georgia Health System, nearly 30 years in the industry as an executive, most recently here in Georgia, prior to this in Florida and in Tennessee, with a wealth of experience regarding CON reform. Thank you.
Thank you, Scott. Next, Ms. Debbie Mead. Debbie, can you hear us?
Yes, I certainly can.
Could you please introduce yourself and have anything to say you'd like?
Well, thank you so much. I am Debbie Mead. I am CEO and owner of Health Management. I have several skilled facilities, post-acute facilities, and assisted living. It is my pleasure to be a part of this committee, and again, my apologies for not being there, but I will certainly be there in the future. Thank you so much.
Thank you. We're glad to have y'all tune in with us online there. Today, as the speaker mentioned, in response to House Resolution 603 that was passed last March, we began the first of 4 planned hearings on Certificate of Need modernization. And you might ask why modernization, but as many of you know, CON was first mandated by the federal government in 1974 and shortly thereafter adopted by Georgia and all the other states. The feds repealed the mandate in 1986, and subsequently, the 50 states have gone their separate ways in repealing or amending or continuing the CON regulations. Indeed, Georgia has since modified its regulations several times, but given the rapid evolution of healthcare in this country, it's wholly appropriate that we now investigate the structure and regime best able to provide Georgians with cutting-edge healthcare that's both accessible and affordable. As Speaker Burns has articulated this morning and on many other occasions, moving healthcare forward in Georgia is one of his top priorities. This study committee is intended to be a vehicle that will move us all in the same general direction, making improvements, clarifying ambiguities, and putting behind us as many roadblocks as possible. I want to be very clear that we do not come to these sequence of hearings with our minds made up about the future of CON. We will rely on no preconceived notions, and yes, we do want to hear about the issues, the problems, the concerns, but our focus will be on discovering the solutions to such complaints. We want our eventual recommendations to be based on facts, evidence, and fairness. I don't have to tell this room that healthcare is very complex. What we want to do is study the issues and the opinions from every point of view, which includes holding meetings in Augusta and Albany to ensure that we fully consider various situational perspectives around our state. Our final meeting will be in October, and it will be back here in Atlanta. My expectation is this committee will subsequently produce recommendations that can be drafted into legislative remedies that encourage providers to offer preeminent health care, whether it be routine, emergent, or traumatic, that's more affordable and increasingly accessible. And now, with this, let's move into our agenda. And let me just mention to you that the purpose of our meeting today is really more of an orientation to get us on the track and get us moving forward. If we have a few minutes at the end, we have a sign-up sheet out there that Tara has put out. For anybody that wants to have to speak, we'll be glad to hear from you. But before we move into this, let me introduce a couple of folks to you also that we have with us today. We really have the A-team working with us on the committee. Tara Bookhalt, who is in the House Budget and Research Office right here, she really runs this thing. Anything you need, she's the lady you need to talk to or get with her. Betsy Howerton over in Legislative Council. Certainly, she's been working with many of you on healthcare issues for a long time. And Ivy Birch, who's in my office, my assistant over there. We're very fortunate to have these and others helping us as we move through this. Let me begin by calling our first presenter, Samantha Scotty from National Conference of State Legislatures, NCSL. Got to come up and we'll have her presentation and give us a good overview of what's going on, okay? Let's see which one. Here we go.
Wonderful. Want to make sure everyone online can see my slides as well. All right. Well, thank you so much for inviting me to be here today. I'm Samantha Scotty. I'm a project manager with the National Conference of State Legislatures. I've been with NCSL for 8 years now, and previously I served as legislative staff for the Health Committee in Colorado. And again, we really appreciate being invited to be part of this discussion today. So a very quick overview of what I'll cover today. I'll provide a refresher of who we are at NCSL, then provide some background related to Certificate of Need and a national overview, and then provide a deep dive into Certificate of Need programs in a couple of states, highlight some recent Certificate of Need legislative updates, including some similar task forces and their related reports, and then wrap it up by highlighting some various research studies regarding Certificate of Need. So as a quick reminder, NCSL is your bipartisan membership organization. So we serve all 7,386 state legislators and over 20,000 legislative staff across the 50 states. And it is our mission to strengthen the legislative institution, and we do that through a number of different vehicles like today's presentation. So here are listed a few of the services that we provide to you all as legislators. And before diving in, I did just want to emphasize and note that any of the policies or state examples that we provide today are purely for informational purposes. That does not indicate we support those specific policies. Again, we are a bipartisan membership organization here to provide you all with nonpartisan information. So hopefully this can help serve as a 101 state national snapshot of what's happening in other states. So starting with a background related to Certificate of Need and a national overview. And I understand some of this, you might be familiar with some of this information, but we thought it would be helpful as this is your inaugural meeting. So Certificate of Need laws require healthcare facilities to seek state approval prior to major capital expenditures or projects. So for example, a nursing home expanding their bed capacity or a health system opening an ambulatory care center. A state health planning agency like a state Department of Health or other entity then reviews the proposed projects and determines whether or not there is a need based off of a variety or host of different factors, like the new project's effect on healthcare costs or what other types of services are currently available in that given service area. So as you all know, Certificate of Need can be a bit controversial, and proponents argue that it can bolster access and control costs, and opponents argue that it has the opposite effects on access and costs. So specifically, proponents contend that the law can ensure services aren't concentrated in more affluent areas, and opponents argue that the law protects incumbent providers and the application and review process may inhibit service expansion in underserved communities. So a quick history related to certificate of need, and I know Chairman Parrish referenced some of this, but as you know, in 1974, the Federal National Health Planning and Resources Development Act was passed, and this required all 50 states to have some sort of structure involving obtaining approval from a state health planning agency before a major capital expenditure project was approved. So essentially a similar model to the certificate of need programs you know today. This legislation did withhold funds from any state that did not enact certificate of need programs. So eventually all states except Louisiana enacted a law, and then that federal mandate was repealed in 1987, as Chairman Parrish mentioned, along with that associated federal funding. In the decade following that repeal, 12 states discontinued their certificate of need program. And that brings us to today, where 35 states and DC currently have certificate of need laws in place, as indicated here on the map in green. And these laws vary widely depending on the facilities and services regulated. So for example, the majority of states regulate various types of facilities like hospitals, nursing homes, outpatient clinics, and a handful of states regulate fewer facilities, specifically Ohio, Montana, and South Carolina, limit CON review to long-term care facilities, and Florida limits CON review to long-term care facilities and hospice facilities. There are 3 states, as indicated here in orange, Arizona, Minnesota, and Wisconsin, that do not officially operate certificate of need programs, but maintain certain approval processes that are similar. So I will cover those CON variations later in my presentation. And it is important to note, in those states that do not operate certificate of need, there is still accrediting boards or licensing agencies that regulate facilities and ensure that those facilities meet certain conditions of licensure or certification, like staffing ratios or other quality and safety measures. And we know that the topic of CON can be a bit jargony, and there are a lot of associated terms when discussing CON. And so to help ensure we're on the same page, I've included some of those common terms here that are associated with CON statutes in state. And a lot of these definitions are taken directly from state statutes. And I will not read all of these because I know you'll have these slides in front of you, but just a couple that are particularly relevant to my presentation today. The oversight entity is a state Department of Health or other health facility licensing agency that operates the state CON program. The regulated facilities refers to any real property or equipment owned, leased, or used by the healthcare institution to which CON review process is applied. And then regulated health services are any clinically related, diagnostic, curative, or rehabilitative services provided through those healthcare facilities. And now shifting to a deep dive into a couple of state CON programs. And again, keeping those first 3 terms in mind, I'm going to review the oversight entity and regulated facility services for a couple of states. And I will also provide details into the considerations the oversight entity then applies to CON review in those states. So the first example is Tennessee. So the CON process in Tennessee lives within the Tennessee Department of Health. Specifically, the Health Services Development Agency reviews CON applications, and the Division of Health Planning sets standards and requirements for demonstrating CON. And Tennessee regulates a combined total of 26 facilities and activities as listed here on the slide. And Tennessee outlines a 13-step process for the CON application and review process. And this includes steps like filing a letter of intent between the 1st and the 15th of the month, a presentation from the applicant to the oversight entity, supporting and opposing testimony, and then the commission's voting process. Tennessee does provide specific criteria that is considered for each CON application. So for example, for freestanding emergency departments, the determination is based on existing access to emergency services within the proposed area and whether limited access is currently an issue. And for consideration related to residential hospice services, the criteria is based on a hospice need formula. And this looks at the average number of patients in a service area and then the annual deaths in that area for the past 2 years. To highlight some recent legislative changes in Tennessee relating to certificate of need, in 2021, the legislature passed House Bill 948 that removed CON requirements from a handful of formerly regulated facilities, including mental health hospitals, and exempting need for the reopening of a closed hospital in a rural location. So that is a hospital that had closed within the last 15 years. It also reduces the application process from 135 days to 60 days, so essentially cutting that review process in half. The next state example I'll highlight is North Carolina. So the North Carolina Oversight Entity is the Healthcare Planning and Certificate of Needs section within the Department of Health and Human Services. And you'll see a list of the examples of regulated facilities and services here on the slide. And the application process is similar to what I outlined for Tennessee, including application submittal, public comment and public hearing, and then the opportunity for appeal. So to determine CON criteria in North Carolina, the North Carolina State Health Coordinating Council, which is an advisory board consisting of 25 members appointed by the governor, they annually prepare a state medical facility plan, and that outlines the specific methodologies for determining need in the state. So recent legislative changes to highlight in North Carolina include a bill enacted just this year in March of 2023. This is the bill that authorized Medicaid expansion in North Carolina and also included several certificate of need modifications. So some of these modifications included removing psychiatric and chemical dependency treatment facilities from CON and increasing the diagnostic center threshold from 1.5 million to 3 million, so doubling that CON diagnostic center threshold. So it's important to note that the changes that I just referenced went into effect immediately upon passage of that legislation. And then there are also some additional CON changes that go into effect 2 and 3 years after the Healthcare Access and Stabilization Program payments are issued in North Carolina. And those are payments provided to acute care hospitals with increased reimbursement funded from a provider assessment. So 2 years after those payments are issued, North Carolina is going to exempt qualified urban ambulatory surgical facilities, and 3 years after those payments, exempting MRI scanners in urban counties. And they define an urban county as a county greater than 125,000 individuals. And finally, bringing us to Ohio. So Ohio Certificate of Need entity is also within their Department of Health, and their program only applies to long-term care facilities as defined in their statute. And they define long-term care facilities primarily as nursing homes in their statute. And Ohio regulates 7 different activities related to long-term care facilities, as seen here on the slide. And they have a number of considerations for their review, including the impact of the activity on costs of long-term care services in the service area and quality of services provided as a result of CON. And then similarly, the application must include, similarly as Tennessee and North Carolina, it must include a timetable of the project, identified project site, and a plan for implementation of proposed project. And now bringing us to those 3 states indicated in orange at the beginning of my presentation. These states do not officially maintain a CON review process, but they maintain approval processes that function similarly to CON. So first, Arizona maintains a program that they have termed Certificate of Necessity, and this regulates ground ambulances in specified service areas. And the applications are submitted to the Bureau of Emergency Medical Services and Trauma within the Department of Health and Human Services. And the department then applies criteria for review, such as geographic service area, level of service provided, like advanced life support or basic life support, hours of operation, and response time. And then the next 2 states, Minnesota and Wisconsin, are unique because they each maintain a moratorium that prohibits the establishment of a new facility or new facility beds, and does allow for exemption from the moratorium in certain situations. So in Minnesota, the process for exemption is outlined in state statute, and the legislature actually retains the decision in granting that exemption. Now to highlight some recent certificate of need legislation. So we have seen a good deal of introduced and enacted legislation over the past years. In 2023 alone, we've seen at least 5 states enact legislation modifying their program in some capacity. So the legislation highlighted here has all been enacted within the last 4 years. And when looking at the sorts of legislation states have been enacting, we could bucket these into 3 main buckets: substantial reform, targeted modification, and establishing additional CON requirements. So I've included some examples related to each of those categories here. As I previously mentioned, Montana and South Carolina limit CON oversight to long-term care facilities, And Florida enacted legislation in 2019 limiting CON review to hospice and long-term care facilities. Many other states make targeted changes or reforms to their CON program, such as exempting certain facilities or activities from approval. So for example, Washington enacted legislation in 2020 exempting rural health clinics in areas with home health shortage areas from CON. Kentucky recently included conditions for ambulance services to be exempted from CON in their state. And West Virginia just this year enacted legislation exempting birthing centers from CON review. And then lastly, some states enact legislation to increase CON oversight in certain areas. So Illinois and Nevada enacted legislation requiring healthcare facilities to seek CON approval prior to closing a facility. In Nevada, that includes hospitals, but in hospitals in counties of 100,000 or more. And then New York recently required a health equity assessment to be filed with certain CON applications. So a handful of states have, similarly to this group, convened task forces or study committees to examine CON in their state. And these are all very recent legislatively mandated committees. So both Kentucky and South Carolina this year enacted legislation to study CON. The South Carolina study was wrapped in with their CON reform that limited CON to long-term care facilities, and does include a specific charge to look at the effect of access in rural areas. And since both of these states are newly created task forces, they have not produced their reports yet, but they are charged with issuing recommendations similar to this committee. Connecticut also recently established a task force consisting of 5 distinct work groups to look at 10 different matters related to certificate of need. And some of these matters included things like looking at quality due to healthcare consolidation and enacting higher penalties for non-compliance of CON. And the task force has released their recommendation report, and it included different recommendations in response to those 10 different factors. And for example, some of the recommendations included expanding the process to allow oversight entities to consider service quality in their review process. And service quality is based off of generally accepted, nationally recognized clinically best practices. The specific work group tasked with studying the benefits and consequences of removing CON did not submit recommendations or findings to the task force. And then another bill to highlight, not on this slide, just this month, Maryland enacted legislation requiring a study of expanding CON over the acquisition of nursing homes. And that legislation does charge the legislature with producing a report. And we've also highlighted a handful of similarly legislatively initiated studies looking at CON that predates these studies that I just mentioned. These studies range from 1999 to 2015. So we felt these were important to include based off of the scope of the ask of our presentation, but I did separate these out because they are older examples, and we know a lot has changed within our healthcare delivery system in this time period. So I have included links to the initiating legislation for each of these states and the full report recommendations issued by these states. So if you'd like to dive deeper into the methodologies used to come to these conclusions, but I will just highlight a couple of the recommendations that came from these reports. So first, Illinois adopted a resolution in 2006 to evaluate CON, and the state contracted with the Lewin Group to produce their report. And I will quote what the conclusion of the report came to. And this report said that the traditional arguments for CON are empirically weak, and based on the preponderance of hard evidence, the recommendation should be to allow the program to sunset. However, given the potential for harm to specific critical elements of the healthcare system, we would advise the Illinois legislature to move forward with an abundance of caution. Non-traditional arguments for maintaining CON deserve consideration until the evidence of the impact that specialty hospitals and ambulatory surgical centers may have on safety net providers can be better quantified. So essentially, they released a recommendation with some caveats that more research was suggested. And a specific recommendation from that report was to extend the program for additional 3 years in order to review the available evidence regarding CON. And currently, Illinois' program is scheduled to sunset in 2029. Next, we have Virginia. So Virginia enacted a Senate bill in 2015, similarly looking at CON. And the work group's final report recommended keeping the CON program and included 34 specific recommendations focusing on making the program more timely, predictable, and transparent. An example of one of the recommendations in that report was to streamline the application process. And the report also identified various facilities that they recommended to be exempt from the CON process, including obstetrical services and magnetic source imaging. Virginia has since enacted a handful of bills modifying CON. For example, in 2020, they required the oversight entity to consider the impact of the proposed project on all individuals, not just those in the specified service area. And then finally, bringing us to Washington, they enacted a Senate bill in 1999 setting the effects of certificate of need, and the study found that certificate of need had not controlled overall costs and spending or hospital costs, but the study found conflicting or limiting evidence about the effects on quality and availability of healthcare services. The study also identified both strengths and weaknesses of the state's CON program. The state ultimately decided to keep their CON program, which is still in place in Washington, and a handful of bills have been introduced modifying the program, including the bill I previously mentioned relating to rural health clinics. And then just this year, Washington also enacted a temporary exemption for kidney disease centers. And in 2019, they exempted psychiatric beds from CON review and ambulatory surgical facilities under certain conditions. And finally, bringing us to some research and studies related to certificate of need. So there are a handful of studies attempting to answer different questions regarding CON, like what are the effects on cost or quality, similar questions as you all are considering in your task force here. And these studies are dense and the methodologies look very different across studies. And so I'm providing a snapshot of just a couple of studies published in various journals. And we know that there are more studies out there. And I'm not an expert in examining the research methodologies of these studies, so I'm not going to summarize all the outcomes and the different nuances, but generally the evidence related to certificate of need is somewhat mixed. And some CON researchers, specifically the team conducting the meta-analysis seen here as the first study referenced on the slide, found that the literature has not yet reached a definitive conclusion on how CON affects health expenditures, outcomes, and access to care. So I would just like to note some important considerations when examining different CON research or studies. So comparing CON programs across states can kind of be like comparing apples to oranges, because one program may regulate one facility type, one may regulate 26. And also that cost and quality are a tricky thing to measure or determine factors for causation. So we know that healthcare costs in a community are driven by a number of factors, like health status, prevalence of chronic disease in that community, age of that community. Also, we know that costs are driven by different prices charged by healthcare providers and hospitals. So again, just some considerations to keep in mind when looking at what the study is analyzing. And again, that's why it might be hard to compare generalized programs across states or also compare studies that are analyzing certificate of need. But I am happy to follow up with more information relating to these studies that we referenced here around methodology and outcomes. And so with that, just to highlight a couple of additional resources we maintain on certificate of need. So we do have a certificate of need webpage that includes all 50 state statutes related to CON and breaks down the specific facilities and services regulated in that state. And then we also track enacted legislation related to certificate of need in our health costs coverage and delivery database. And with that, of course, reach out anytime. My contact information is here, and I will turn it back to the chair.
Samantha, thank you very much. Do we have comments or questions from the committee members? Dr. Newton.
Yeah, thank you very much for your very thorough evaluation. I was really interested in your map. In particular, for example, South Carolina, I think you said now they only deal with skilled nursing facilities and not hospitals. So CON no longer applies. So it kind of makes them more blue than green. And then, of course, I think Minnesota and Wisconsin, you said, have moratoria on new hospitals, even though they don't have a certificate of need law, which, of course, is probably stronger than even a certificate of need process to get around. When you do the studies, or when people do the studies, how in the world do you, when you mentioned CON can apply to 1 to 26 different things like skilled nursing facility or everything or exclude psych. How do you get data that show a before and after? And then, of course, we need it to be a state similar to Georgia with, as Chairman Parrish, 59,000 square miles. I mean, a pretty big state.
Great question. So when we pull this data, looking at certificate of need laws in specific states, we look at the state statute and how they define healthcare facility and which facilities they apply that CON review to. So that's where we're pulling this information related to the 26 facilities and services or the statute in South Carolina, just applying certificate of need to long-term care facilities. So that's where we pull this data from. To compare Georgia to some of those states, you could then pull Georgia's state statute and then look at kind of the number of facilities and services regulated.
Well, thank you for these resources. They're going to be valuable.
Any other questions from the committee or comments? Good, Samantha, thank you.
Okay, thank you so much.
Leader Beverly is with us, and would you please mash your button and introduce yourself there? We're glad that you could make it today. Thank you.
Thank you very much, Mr. Chairman. Good morning, everyone. I drove up from Macon, Georgia, and there's nothing I like better than leaving Atlanta and having it in my rear view, and I don't look to come back anytime soon. And the reason is because the traffic is absolutely ridiculous coming from Macon to Atlanta. Anyway, I'm glad to be here, Mr. Chairman, and would like to contribute as much as I can to this esteemed committee. Thank you very much.
Great. Thank you. Next on our agenda, we're going to hear from Russell Carlson and Carisha Lang with Department of Community Health. Russell will be set up.
Thank you, Brandy. Mr. Chairman, members of the committee, my name is Russell Carlson. I currently serve as Chief Health Policy Officer for your Department of Community Health. On behalf of Commissioner Kaylee Noggle, we'd like to thank Speaker Burns, Chairman Parrish, and the House staff for inviting us to present to the opening session of the House Certificate of Need Modernization Committee. Joining me today is my colleague, Carisha Lang. Carisha serves as the Executive Director of the Office of Health Planning at DCH. Carisha's team administers the Certificate of Need program for the state, and today she will be sharing with you an outline of the legal and administrative framework of all our processes. As you will see, much of the process is in fact statutory. As you'll see, your presentation is littered with citations. We take much of our direction from what the legislature and the governor puts into law. But as you know, the department is in a unique position in these kind of conversations. In fact, the commissioner herself is directly tied to the appellate process. But that being said, we're not here by accident. In the spirit of the chairman's comments, facts, evidence, and fairness orientation, we think we can provide an overall framework at the outset of what your current law is, our current process and regulatory framework is. But our goal here is to not only inform you, but also to learn. We're looking forward to this dialogue. We always want to stay sharp, best practices, feedback from the field, research. Our goal is when the laws change, we want to change with them. We want to pivot. We want to be educated and informed to assist in this process and to administer policy and law fairly and efficiently. So with that in mind, Mr. Chairman, I'll introduce again my colleague, Carisha Lang, Director of Office of Health Planning for Department of Community Health.
Thank you, Chief Carlson. Good morning, Chairman Parrish and members of the study committee. I will be providing a high-level overview of the Certificate of Need program, which I will refer to as CON going forward. As you know, CON laws and regulations and the attendant procedures are vast. So if there are any specific details that you would like based on the overview that we provide today, happy to report back with additional information. Okay. So the Certificate of Need program sits within the Department of Community Health. Can you go back for a minute? And the purpose of the Department of Community Health, the mission of the Department of Community Health is to provide Georgians with access to affordable, quality health care through effective planning, purchasing, and oversight. Like DCH, I know that you are all committed and dedicated to a healthy Georgia. Consistent with that, the CON program's purpose is to ensure adequate healthcare services and facilities are developed in an orderly and economical manner and are made available to all Georgians. Only those healthcare services that are found to be in the public interest shall be provided in the state. In Georgia, a CON is required prior to the development or expansion of regulated healthcare facilities, services, or expenditures, including the list you see before you. Some examples are short-stay general hospitals, psychiatric and substance abuse inpatient services, and a variety of other capital expenditures by a healthcare facility that exceed $13.2 million. Certain services and activities in Georgia qualify for a statutory exemption from CON review. There are 31 statutory exemptions available at OCGA 31647, and they include the relocation of facilities under certain circumstances, as well as certain ambulatory surgery centers. So diving a little bit into the actual review process, CON applications fall into two categories. Those are non-batched applications and batched applications. Non-batched applications are accepted throughout the year. Batched applications are accepted only during designated times a year, generally as follows. During the spring and fall, home health services, skilled nursing facility services, perinatal services, and then during the winter and summer, positron emission tomography, we call those PET services, radiation therapy services, and so on. Just last month, the end of June, we issued the batching notices for the summer 2023 cycle. And we indicated that we will be accepting applications for psych services, inpatient rehab services, just to name a few. Those applications are due the end of August. So here is a slide of the review timeline and the applicable review milestones as provided in OCGA 31643. I would like to point out that the standard review timeframe for applications is 120 days. You will notice that there is an opportunity to extend that review period for an additional 30 days for a total of 150 review period. The next slide is the timeline for batched applications, which is largely the same as the previous slide, but there are subtle differences. Most notably, there is no provision to extend the timeline for batched applications beyond the 120-day review period. So now that we know what services are reviewable generally and the associated timeframes, what standards do we use to evaluate applications? Well, OCGA 31621 requires that the department establish by rule need methodologies for new institutional health services and healthcare facilities. That methodology is found at 111-2-2. The need methodology for most service-specific rules includes an objective numeric need standard, which is used for calculating need for specific services, including short-stay hospital beds, perinatal services, skilled nursing facilities, to name a few. Applicants may seek an exception to the numeric need standard as permitted in the applicable service-specific rule. Available exceptions may vary by the specific rule in question, and they largely intend to allow for the development or expansion of services when special utilization factors or atypical barriers seem to warrant. For projects that are believed to be exempt from prior CON review and approval, a request for a letter of determination, commonly called a DET, is filed to confirm that exemption. The department typically issues a response to a DET request 60 days after its filing. There is an opportunity for the department to extend that review period for an additional 30 days. So the next slide provides a breakdown of CON by the numbers. Here, we just tried to isolate CON activity for fiscal year 23. The appeals information reflected here reflects the final disposition as of July 7th, 2023. I would note that there are several CON applications and DETs that are still pending. Still taking a look at CON's numbers, on average, 51 applications are received each fiscal year. In terms of DETs, we average about 346 requests each fiscal year. Of those 346, about 94 annually were related to equipment expenditures, acquisitions. About 26 involved development of ambulatory surgery centers, and approximately 227 involved other general proposed activities. So taking a look at the appeals process, CON decisions are subject to appeal. And to assist us with those efforts, we have a CON appeal panel. The panel consists of 5 hearing officers that are appointed by the governor. They each serve a term of up to 4 years, and they are legal and healthcare experienced. They have experience in legal matters and healthcare matters. And they review the department's initial decision to grant or deny a CON application. The appeal panel membership is provided before you. CON appeal panel decisions may be appealed to the commissioner, and the commissioner's decision may be appealed to Superior Court. When the department makes a determination or decision over which the CON appeal panel lacks subject matter jurisdiction, the person who requests and receives the determination or decision may appeal to the commissioner or his designee for an administrative hearing. The determination appeals relative to the DET request I mentioned earlier, they would be assigned to the hearing officers you see listed before you. Like the CON applications, those decisions can then be appealed to the commissioner and then ultimately to Superior Court. Finally, the tail end of the CON process involves post-approval activities. Post-approval monitoring ensures project implementation and completion regulations are complied with. Additionally, the state architects provide a review before the application is completed, and then after the application, the project is completed, and they would issue the applicable occupancy certificates. Lastly, as part of our data collection efforts, we collect annual utilization and financial data from CON regulated facilities. We administer about 10 different surveys to approximately 1,100 facilities. We ensure that indigent and charity care commitments are met, and we use that data to publish our threshold calculations and to determine our need calculations, which are issued, used for our batching notices, which are issued quarterly. And on the last slide, you will see additional resources to help guide your just general knowledge about CON. Chairman, do you have any questions for us?
Question, Representative Beverly, okay, go ahead.
Thank you, Mr. Chairman. I have just a quick question. How many or what percentage are approved out of the amount that comes through? How many and what percentage are approved?
So that's an interesting question. Brand, if you could quickly turn back to the CON by the numbers slide. So, and I say that's an interesting question because you have to take into account the final disposition of the decision. So meaning if it gets appealed, ultimately, it takes a while for us to know where we stand finally with that project. But if we just did the rough math based on fiscal year 23, we lost our slide. Okay, does the math? Yeah, a little bit over half were approved during fiscal year 23.
Did they get this? Yeah, Chairman Cooper.
Thank you, Mr. Chairman. I guess my question is really about that final disposition and how many, when, you have your timeline, when you issue an approval or a disapproval. The first question would be, who can appeal and object to that decision? Who can make those objections?
So I'm trying to get you the citation. There, in code, there is very explicit language about what parties have standing to appeal and first they have to oppose the project and then ultimately appeal the decision.
Okay, well, if you could just give me a quick example, or let me say, would it be like if a hospital is going to appeal a decision you made about another hospital? Years ago, Wellstar wanted a cardiac unit, and y'all gave approval because there was enough people that needed open heart surgery to have that special cardiac unit. And I think it was appealed by another metro hospital. Could a hospital in South Georgia have appealed that process also about something about Wellstar's cardiac unit?
Right. So in code, there are parameters for who can appeal. It limits parties who may be interested to opposing initially and then appealing to a 35-mile radius. And then they must also provide substantially similar services.
Okay, and if one hospital lost that appeal and it looked like Wellstar was going to go ahead, could another hospital come back in that same radius and appeal again? I mean, one of the complaints that we get is that once y'all have given, and just what I'm trying to get at, and without going to, once y'all give approval and have gone through this extensive process and think that whatever the services you need is that then it is appealed through the court system, costing hundreds of thousands of dollars, and then it gets appealed again by somebody else. And, so I guess that whole delay process was one of concern to us, because I guess I'm trying to say, is there just endless appeal processes if you go to the courts? That
I can
sort of bad.
I can appreciate your line of thinking on how many parties can appeal, and especially if they wait till one's adjudicated and then up comes another appeal, how that adds to the. Yes, so I can appreciate your logic. I think we need to fine tune that answer to make sure we're right on the process. I can appreciate your logic. So let me just kind of really make sure we're pinned down on the process of when one appeal has run its course, can another party then appeal?
I think that's fine, and I will appreciate that, because I think that's one of the major concerns that we get, and it's across the board, whether it's nursing home, hospital, surgical center. It's one of them. See the doctor agreeing with me. One of the major concerns that we get over and over again, and so I would appreciate that. And and my concern is, first, it delays care, and the other is that it just uses up hundreds of thousands of dollars that could go to patient care. So I really would like to look at that. Thank you.
Yes, ma'am.
Good, thank you. Dr. Newton.
Thank you. And thank you for your presentation and for y'all's work. It is a complicated thing. If you could answer on the need determination, and just, for example, using Chairman Cooper's example of a cardiac facility, do y'all use some sort of a minimum number of procedures, whether it's directed radiation for cancer or cardiac interventions? If you need 300 a year to be good at it, or 100 a year to be good at it, but a facility down the road is doing 900 and somebody wants to apply to do some. Do you use the fact that there is a minimum number you don't want to go below? You mentioned best practices and generally accepted quality. Do you use the fact that there may be minimum quality numbers, and then only if somebody's saying that their number is going to go below the minimum quality number would they be against, be able to appeal the CON, or I'm sorry, oppose someone else's provision of services? Does it depend on the type of services that you do? And do you use an outside entity to tell you what is the minimum number of stereotactic radiation, for example, or a PET scanner or something else? If you're doing 500 a year and somebody wants to come in and also offer that service in a little different area, but within the 35 miles, how do you do that? Does it depend on the service, and what quality metric do you use for cardiac interventions, for example?
So that's an interesting question, and I think it's a multi-tiered question. So to the first part of your question, yes, there are certain thresholds depending on the service in question. For example, radiation therapy has a threshold that goes into the numerical needs standard I mentioned earlier. In applying those thresholds, the outcome could show that there is numerical need or not. If there is numerical need, like in the example that you've outlined, an applicant can request to submit an application based on an exception to need. So in an instance where you may have a provider that might be underperforming or something to that extent, if additional services are thought to be needed in an area, an applicant can submit a request to the department explaining that dynamic, looking at the existing provider, what services they currently offer, to the extent that those services reach the population that they're targeting. Those factors are looked at in determining whether an application would be needed in spite of the existing one of another provider, if that makes sense. So yes, arguments like that in terms of how many patients are actually being served by any current providers are factors that we want to hear about and that applicants provide to us to help us with these analyses.
Thank you.
Thank you, Mr. Chairman. I appreciate the data you provided, the current data. Is there somewhere, a repository, somewhere we could research and see historical data, like 5 or 10 years?
Yes, so on the department's website, there is a repository where all certificate of need decisions and all attendant documents are located. We can forward that directly
That'd
to
be
you
great.
if that'll be helpful.
Thank you. Does it have final disposition? Like on appeals?
If they're available, yes.
Okay.
All documents are included.
All right, thank you.
Mhm.
Good. Scott Rames is online and has a question for you.
Thank you guys for being here today. A couple of questions unrelated, if I may. And you may have just answered one of them. As far as length of time with regards to approval or denial upon submittal, do you have any data or any way to kind of piggybacking on what Representative Cooper had asked? Do you have any way to share what that time frame would be from submittal to approval or denial? And if you don't, would it be possible for us to research and find that out, or could you possibly share that with us? So that's question number one. Question number two, and I'll be succinct. I believe that in 19 additional modernization or work was done with regards to CON law and requirement. But my impression is not all of that has been fully implemented, largely due to the pandemic and just the chaos that ensued as a result of the pandemic. Would you be comfortable speaking about what has and has not occurred with regards to those recommendations that were to be implemented in 2019? Thank you.
So to the first question, yes, we would be able to research and pull information about the time frame from submitting an application to the actual final disposition. So we can definitely follow up with that information.
Great,
And-
thank you.
One follow-up question regarding that, over what time period would you be interested in?
Yeah, I think it'd be perfectly fine for you all to define that, but I think 3 years, 5 years would be plenty good and probably manageable, given the data that you shared on what you're seeing in annual submittals.
Okay. And then to your second question, yes, in 2019, there were some updates to CON procedures and processes. What I will say is that to date, those have been implemented. One of those updates was to increase the capital expenditure threshold, which was increased to $10 million. Right now, we're at 13 million. That adjusts annually. Another update was, similarly increasing the equipment expenditure threshold, which is now just over $3 million, which also adjusts. Some other changes, there were additional exemptions added to the code. All of those are in play, and those are just a few that come to mind readily. I'm trying to think if there were any that were not implemented, and I think they've all been implemented. We've updated our rules accordingly. And so, all of the changes in code are reflected in the rules.
Yeah, thank you very much. I knew that there had been changes made and recommended in 19, and I just wanted to get a better feel for, given the most recent recommendations, were we completely compliant, or compliance probably too strong a word, but had they been implemented fully, and are we experiencing those as well in the current state? So thank you both very much.
Yeah, can you just refresh my memory on those capital expenditures? Were those just for hospitals, or did they cover the surgical centers also?
Those are for all capital expenditures.
Okay, so they did cover the freestanding surgical
Yes.
centers. Okay, thank you.
Yeah, thank you guys so much for walking through this. I really appreciate it. Question regarding some of the goals that you're looking at as it relates to the replacement of capital, and what your intentions there.
I'm sorry, could you?
Yeah, just when we're doing the replacement of capital, I think it's the $3 million, as you mentioned, basic replacements, kind of some of the evaluation information on that.
So there's an exemption for acquiring equipment, certain diagnostic imaging, therapeutic equipment by hospitals or physicians meeting certain criteria. That is for an acquisition, not a replacement. So for example, if you had a hospital that wanted to acquire a CT scanner, and that unit was below, I think we're at 3.2 million now, there is an exemption whereby they don't have to go through the full CON review process.
Thank you.
Thank you, sir. Just a follow-up question on the determination of need. I know we have some critical access hospitals around the state that have 25 beds, and they may have an average daily census of 6 or 9. So if you looked at that area, you would say there's no need for any kind of new healthcare there because they've never filled up their hospital. But it might be that people are driving 30, 40, 60, 90 miles to go to a modern facility, and if there was one closer, they might want to go to that one. I'm curious, does our current evaluation of need allow you to recognize that even though there is no need based on the fact that there are empty beds at a small 50-year-old hospital, does it allow you to calculate that, well, maybe there would be a need, there is maybe a need if you look at the driving distances people are doing? Does our current law allow you to look at the distance people are driving instead of utilizing a facility or something like that? Or is it pretty strictly I don't know how strict the regulations have been, either from the legislature or from the earlier regulatory. How do you determine that?
So the numerical need standard is just one aspect of our need methodology. And so whether or not there's numerical need, there's an opportunity for applicants to make an argument that regardless of what the numerical need calculation suggests, there's this other need that's not calculatable, that cannot be calculated. And
Or to
so
present an example like yours, capacity versus say an average census.
right. And so factors in terms of geographic accessibility, if services are located too far away, financial access, if for reasons related to an inability to pay precludes some folks from accessing care, though, and quality generally. Those are the types of arguments that applicants would present to the department in instances where there is not a numerical need in order to support need for their project. So yes, there is several opportunities for an applicant to make that type of argument.
But once again, back to Chairman Cooper's point, I guess if you did determine that a need really did exist because of drive times or whatever, there's obviously nothing to stop the smaller place from appealing with that, not the 150 days, but what we have seen is 3 and 4 and 5 years of the court system, which is not your fault.
You're understood. We will get back to the committee on a more defined table demonstrating the various appellate processes and what does and doesn't exist, because I can appreciate what you both are saying, how that contributes to the timeline. I just want to make sure we have a firm representation of the law on who has standing to appeal and the frequency by which that happens.
Okay. Leader Beverly has a question.
Thanks. Just a real quick question. Has the ASC reporting requirements been fully implemented? So ambulatory surgical centers, has the reporting requirements been fully implemented up until this point?
You're referring to their requirement to submit survey data?
Yes.
Yes.
Okay. Do we have any other questions from the committee or comments? Thank you all for your presentation. And I think one thing we can learn from this is CON is a complex issue. It's not a one size fits all. And certainly we don't have all the answers. It's like one of these whack-a-mole deals. You hit them on this side and they pop up over there on that side. So, but thank y'all, and we look forward to continuing the dialogue as we move forward. Thank you
for allowing us to be here.
Okay, next on our agenda, we're going to hear from Anna Adams and Carrie Conley with the Georgia Hospital Association.
Thank you, Mr. Chairman, members of the committee. My name is Anna Adams. I'm with the Georgia Hospital Association, and we have the privilege of representing 145 hospitals in the state of Georgia, ranging from small rural all the way up to large metropolitan hospitals. And we are very grateful to be able to be here with you today to talk with you about Certificate of Need and to share with you some of the things that we have been working on since session adjourned. So I wanted to first just give you kind of an overview of where we wound up after last legislative session. We were working closely with stakeholders on some of the legislation that had been introduced and was moving. And in response to that, after you all adjourned sine die, we put together at the direction of the GHA board a CON working group. This group consisted of 19 people from varying hospitals across the state, and we had very robust meetings about what the program is, whether changes needed to be made, what modernization we could come up with to next session come to you and make our own proposals. We want to be a partner. We want to be at the table. And so we have prepared for you today a notebook that you all have in front of you. And we wanted to go through that a little bit briefly too, because many of the questions that you've already answered or asked today, there is data in here that answers those questions. So grateful to the previous speakers for their presentations. I think our overall overarching goal in this discussion with our membership and with other stakeholders has been to just make sure that everyone is pretty clear that healthcare is very, very complicated, as you all know, and we can't consider CON in a vacuum. It is one area that perhaps needs some modernization. We agree with you on that, but there are other areas as well that I think will help us have better access, lower costs in healthcare in the state of Georgia. And so we are looking at this from a more holistic global perspective and trying to figure out where there are barriers that might prohibit others from having access to healthcare and what we can do to help alleviate some of that. So Carrie Conley is here today. She's our general counsel and our resident certificate of need expert at GHA. And we're happy to answer any questions that you have, but I think you had a couple of points as well.
Thank you, Anna. To follow up on what Anna was just saying about looking at this in from a holistic perspective, we would ask, as you all are hearing presentations and looking at all of the data, that you keep in mind that it's not just certificate of need that has the potential to either address an access issue or add to an access issue, that it's much broader than that. And so from our perspective, it would be really helpful to define the specific issue that you're trying to address. So for example, if it's access to behavioral health services, then let's look at what all of the specific barriers are to getting care to the people who are not currently able to access those services. It may be that there are some tweaks to the CON process that could help with that, but it also may be that there are some much more direct ways that we can influence and increase access to care to a particular area that go beyond CON.
And I'll add to Carrie's point that as we've been having these discussions with our membership, one of the prevailing points has been access to care doesn't mean access to more services, it means access to all services. And so while it's fantastic to have multiple surgery centers in one area of the state, there are a lot of options there for surgery. We want to make sure that we also have options for prenatal care, labor and delivery, emergency department, behavioral health, et cetera. So that goes again with the holistic approach of making sure you have access to all, not necessarily more. And so, Mr. Chairman, I would like to briefly just go over this notebook with you just so that you are aware of what is in it. See if you have any questions for us. But I think what we would like to do, as we have been having our GHA work group meetings, we have had 6 meetings total. We have discussed with our board the recommendations of the GHA CON work group, and we are now in the phase of our planning where we are having membership-wide meetings to get feedback and roll out sort of what our recommendations are, see if we need to make any changes. And so there are some details in this notebook as well on the items that we've discussed. We would love the opportunity after we have shared with our membership and our board has signed off to come back at a later meeting and review with you what those recommendations are. But for today, wanted to keep it sort of high level and just CON specific. So if you'll look at the notebook at the first tab, we just have a certificate of need fact sheet and glossary because this is such a complicated process. We want to make sure that as we're using terms, we all have the same understanding of what those terms might mean.
And I would add, as we're going through this, much of these are the same materials that we have provided to our own CON work group at GHA. That process we're not just doing it to go through the steps to check a box. It has been a really robust process. I think the work group would say that it's been a learning process for all of us. And so as we go through these things and you have questions, they're likely the same questions that our own members have been asking as well.
Thank you, Carrie.
The second tab, I think has been probably one of the most helpful resources that we've shared, which is a history of Georgia's Certificate of Need program. So it's a year-by-year overview of what changes have been made at the state level. Each item that's listed here that is red represents a statutory change, with the most recent, as you'll see, being in 2019.
One of the things I'd like to point out about the timeline, first, the red, as Anna said, indicates statutory changes so that you can see there has been a number of statutory changes over time. But the other thing I'd like to point out, any time where you see in this timeline in bold state health plan, those are instances in which the Department of Community Health has updated the need methodologies is the terminology that we use typically for those for a particular service. And so that is something, there was a question asked earlier about implementation of the changes that were made in 2019. One of the changes that occurred was to give the department the authority to appoint a technical advisory committee in order to help them update these state health plans. And that is something for resource reasons the department has not been able to do to date. And that is one of the things you'll see. These state health plans haven't been updated in 20 years. So while we have been good about making fairly regular reforms at the statutory level to the Certificate of Need program, we have not provided the department with the resources to fully implement those reforms and update the regulations and state health plans, as you all may be assuming can happen when you make the statutory changes.
That's a great point, Carrie. And so because of that, many of those individuals who have been trying to get certificates of need and have felt as if the program was incredibly challenging, an update to those regulations could be incredibly helpful. So moving forward, there is the next tab. I won't go through each of these, but the CON review cycle timelines, the department reviewed those during their presentation. These sheets are directly from the department's website. So they are branded Department of Community Health, but it is the same timeline that we are still currently using. The following tab, CON thresholds, those are updated pretty regularly. There was an update that came out July 1, and so this copy that you have here needs to be updated as those capital expenditure thresholds have changed. Beyond that, we have included the CON planning maps so that you know what those look like just across the state.
The planning maps are important because the CON program is meant to be a community-based assessment of the needs, the access needs of a particular community. And so along with the state health plans, these maps get updated when those state health plans get updated. So to the extent that things have changed around the state in the last 20 years in terms of where communities are receiving the care or how they are commuting, then it may be that these maps need updating as well.
As you can see, there are different maps for different service lines across the state. The next tab is one that I would like to draw your attention to. This is a House Bill 186 overview that goes over what the law was for certificate of need prior to the 2019 changes and what it is post-change. The third column shows the implementation status of those statutory changes. So you can see when those went into effect and whether or not the department has adopted final rules. Most of these have been implemented. But as you can see, the bigger, more robust changes went into effect in March 2022. And again, that's because of a COVID lag. The next tab is the Georgia CON application statistics. There was a question about that earlier, I think by you, Leader Beverly, about which have been opposed, how many have been filed, et cetera. So we have these here. They are organized by 2019, so post-change to current. And then there is also prior to 2019 so that you can compare those and see what those changes impacted.
And I would add on these, with this data, there was a lot of conversation previously
about the appeals process and when something has actually a final, excuse me, a final resolution. And so that is taken into account in these charts. There is, when something is approved, that means it has been finally approved. If it says pending, then that means it's still going through the appeals process.
Thank you, Carrie. The following, and these might take some time to digest, and I would encourage you, if you have some time, to look at these. It is pretty interesting, which are opposed, which are not opposed, et cetera. The next tab is the existing service map so that you can see where services are located in the state already. The first map comes from the State Office of Rural Health. It shows the rural areas that are lacking a hospital. Beyond that, we have the trauma and specialty care centers on the backside of that page for your reference. We have data about ASCs, where they're located in the state, and we've done that by region so that you can see the concentration. The following tab is a GHA CON comparison of the Georgia versus surrounding states. Representative Newton, you had asked about that earlier. How do you compare when each state is so different? This at least compares Georgia, Alabama, North Carolina, and Tennessee. So you can see which are implemented in which states, which are more open, and which have more restrictions. The next tab is an overview of our GHA Certificate of Need work group meetings. So we've included the agenda for each of our meetings so that you can see the items that we discussed. These were very targeted meetings, and we tried to consider the legislation that has been introduced over the last several years and the conversations that have been happening so that we could make sure that the group had time to digest and really discuss each of those individual issues. As you can see, the CON work group committee members are listed on the left. And if you go through those, it is pretty diverse from a geographical standpoint as well as a facility type perspective. You can see here as well our timeline. We got to work pretty quickly after session ended, starting April 28th, and had our board review and discussion actually 2 weeks ago, pending that going to the whole membership and what the membership's feedback is. We are hopeful to have something to you by late summer, early fall. The rest of the tabs that are included here are various studies and just sort of general hospital information. Many of these might be helpful as you're thinking about what impact these changes could potentially have to hospitals. There's an interesting study that's the second to last tab that really goes over Georgia's ranking for healthcare openness and access and how much we improved after, again, the 2019 CON changes. So that's an interesting read. And then finally, our GHA Hospital Handbook, which is a document that we created several years ago for legislators and for hospital trustees that goes over how a hospital functions, how we're paid, who are the regulating entities, et cetera. So we are happy to answer any questions if you have them, but I do want to reemphasize that we are very willing partners. We are excited to continue this conversation, excited to work on modernizing this program in conjunction with some other changes that might be helpful to ensure that Georgia's patients have access to healthcare, affordable healthcare.
Anna, thank you. Looks like we got a lot of homework here to take home with us. Some sort of
Light
open
reading.
book test or something to help you when you can't go to sleep, I guess, some of this. But thank you. Obviously, there's a lot of time and effort put into this and a lot of good information, and we thank you for that. We do have a couple of questions. Before that, I'd like to recognize Representative Dave Seaball there. Devin Seaball, who came in. Thank you, Devin, for being here with us. I know you're interested in this as well. Representative Cameron has a question for you.
Number one, thank you for the information and thank you for your testimony. Could you explain just briefly how the current CON process in Georgia helps control inflation / cost for our constituents?
It's going to be you question.
I mean,
So it goes back to access. So when we're talking about access, we think about access as ensuring that all of the populations in the state of Georgia have access to a full array of services, including emergency services, trauma services, OB, those sorts of things. And when you allow specialty types of services to open without the review for community need, those types of services that don't have to provide the same array of services that hospitals do can pick and choose both who they provide the services to and which services they provide. So because they're good business people, they choose to provide services in communities where they know that they can be paid for, and they choose to provide the services that they know that they'll be paid well for. What happens then is that those services that pay well are moved from the hospital out to these specialty centers and removes revenue from the hospitals. And it then costs more overall for the state to provide access to that full array of services. Because if right now those specialty types of services are helping to finance the hospitals providing access to emergency services, trauma care, OB, NICU, the things that don't pay well, and tend to be used by populations that can't pay. And so if you move those out, the cost to pay for those access to those services is going to have to come from somewhere. And so if we think about opening up CON to allow for these specialty services to come in, we've got to look at it from a holistic standpoint about how are we going to maintain access for everyone. And at some point, it's going to end up costing us more if we want to maintain that access, because the fundamentals of how hospitals are paid don't incorporate the standby roles for the trauma services or being open 24/7 for the emergency department. Those are all incorporated into the payments they receive in part for those specialty services they're providing. And so if you take that away, at some point we're going to be left and wondering how to finance that.
I do want to clarify one point that Carrie made. When she talks about allowing these specialty services to come in, we do have a large number of specialty services already in the state of Georgia. And so one of the things that I think we keep reminding ourselves is that CON for some feels like a barrier, but in reality, CON is the way in. It just happens to have become a little bit of a dirty word. But there are mechanisms in place to allow for these types of specialty services in ways that ensure there is no harm to the community.
Thank you.
Thank you, Chairman. A couple of things. One, just on behalf of all of us with our families and everyone, the hospitals of Georgia really are amazing. And I know you have a piece in there that points out 24-hour emergency care, blood banks, ICU, all the things that you mentioned that are needed to handle complications of things that might be done somewhere else. And I do appreciate that. One of the questions I had regarding your statistics, and it talked about the total number of CON requests, the number that were not approved or opposed. One of the numbers, and I'm sure I don't doubt there's any way to tell how many things the different hospital and healthcare systems in Georgia or healthcare providers wanted to do, but were dissuaded by the potential multi-year appeals process, just the fact that the attorney process, no offense to the attorneys, but that the legal process, which is much longer than just what DCH, what we don't know is how many health systems had great ideas for expanding care, but sat there and penciled out the math on it. It's not going to be a highly profitable service in this more rural area north of Atlanta or far north of Atlanta, or maybe even in southern Georgia. But one of the problems, and I don't know if there's any way to get those numbers or ideas of who would have put something somewhere, but for the fact that the potential CON deterrent, which it is, it can be opposed, it can be denied, it can be appealed, even if it's approved. Is there any way to tell, even with the hospitals, even with your members, how many wanted to do something, but I know a lot of the hospital systems are expanding across Georgia. Wellstar is going to take over the hospital that trains our physicians at the Medical College of Georgia. And so that's a new area for them. Any way to tell how many might have been dissuaded from expanding care, expanding access, maybe even affordability?
That's a great question. And it's something that we had pretty robust discussion about within our CON work group. We don't have that data. It's something that we can try to think about how we could get our hands on it and trying to figure out who may have done that before. But we are in agreement with you that the process as it currently stands is cumbersome, difficult to navigate. And I think once we ultimately are able to share GHA recommendations, we will have some talking points about how can we make this process easier for everyone, so that we don't have people choosing not to file because of process.
That's right. And I would say in addition to that, that part of what certainly people are dissuaded. I mean, I don't think that we can debate that. But part of what dissuades them are the need methodologies that haven't been updated, because it's pretty easy to look at the regulations and do the calculation yourself if you're a math person. I'm a lawyer, so I'm not a math person, but I could probably get my 15-year-old daughter to do it for me. So you can do the calculation and see whether or not there's a need. And if there's not a need, that may very well dissuade you from doing that. But that's something that through those technical advisory committees that you all gave the department authority to establish in the 2019 reforms, we have the ability to update those now. We just need the resources to do it.
It would be interesting if there was a need, somebody opposed it, and there was a loser pays proposition too. Maybe we can talk.
There is a loser pays proposition right now in the statute, and that from the 2008 reforms, whether or not it's enough or if it's working the way it's intended, I think is a legitimate question.
Thank you, Mr. Chairman. First of all, I want to thank you guys for this thorough report. It's fantastic. But I want to draw your attention to the Healthcare Openness and Access Project, the numbers that you guys gave us. There are about 11 categories within that space, 11, 12 categories within that space where we score a number 1, which is the lowest score. What I would ask you to do is, could you all make recommendations from GHA about those 11 categories or 12 categories of what could move our score from a 1 to a 3 or 4 or 5? That would be extremely helpful.
Absolutely. And we are happy to share the website with this via link as well. It's a very interesting project to look at because it is so much larger access than just certificate of need. So the items here that we have ones in are mostly scope of practice and prescribing authority. There are some other areas where we would certainly like to make some recommendations outside of CON as a part of a package so that access is addressed from multiple angles. So we can make sure to include those.
Thanks. And then I just also want you to take a look at what stood out for me is that online eye exams. Obviously, right. I mean, we scored a 1 in Georgia. We just passed this telemedicine eye care thing. So just make sure that the data is updated as you guys go through it so that we can sort of rightly align our priorities. Because if we're the number 1 state to do business, we want to be the number 1 state to have healthcare provision as well. So,
absolutely.
Right, thanks.
And I'll just add that this is not our data. This is data that we got from someone else, and this is a 2020 report. So we are looking forward to seeing the 2022 report, and it should include some changes from this. Yeah.
Great. Thanks a lot.
I guess I need to ask Betsy to get us on how the need methodology is changed. Does that go like that it's put out like rules, or if it's by law, but it's put out by rules? In that case, isn't it my understanding that maybe one of the big reasons that we haven't had some of the updates that we need in need methodology be because of hospital objections to them all the time?
Well, if we go back to the 2008 reforms, it used to be that we had a health strategies council, and we tried to eliminate some of that kind of bureaucratic mess as it relates to updating the CON regulations and the state health plans. But what happened after the 2008 reforms, it used to be that Health Strategies Council was the one that made the recommendations regarding the need methodologies. When we eliminated that, we inadvertently did not give the department the authority to create the technical advisory committees that the department needs to help them with the expertise to update those need methodologies. We fixed that in 2019, but the department has not been able to, in part because of COVID, in part because of resource issues, actually appoint any of those technical advisory committees to make those recommendations. So the hospitals haven't even had an opportunity to object.
And if I go back, I think to remember one of the reasons why I did away with it, just because basically the hospitals ran that group. And so it was hard to make change. I think one of the things that from the presentation, and I appreciate this, and I will, read it, is that when we talk about, and it's mainly in your opposition to the surgical centers, and do hospitals and doctors not sometimes and very often own them in joint? So the hospitals also have surgical centers and they've opened them in conjunction. Okay. So y'all also own them. Is patient positive outcomes for patients? I mean, in this world, as we talk about technology changes, and I remember going to a conference years and years ago, NCSL or somebody put it on and said that by now we wouldn't recognize what a hospital looked like, that it would be very different. And yet here I said, and that was probably 15 years ago, and hospitals look just like they did. And they haven't really changed much since I was in nursing school. And now we're going to build a new one down in Augusta, and I'm sure it'll look very much like that. So with all the technology changes, the hospitals haven't seemed to adapt to that. And there are definite advantages to being able to go to a freestanding surgical center. I mean, it's quicker, it's easier to get into. You're not exposed to all the hospital infections and all that they're going. So there are various reasons. It saves times for the surgeons. It saves times for the patients in waiting and pre-op. It opens up operating rooms for more serious surgeries. And haven't we now, the last time we heard this and over the years, it's been, we do all these services that we lose money on. And, okay. But is it not my understanding now that we're going to pretty much make y'all whole in you doing it? And the other thing that we don't look, that we're going to make y'all whole at hospitals and and going forward. And the other thing I would say is that here again, you don't pay taxes on the property, on anything you buy or you order. And remember that the surgical centers do. And here again, as we look at this, one of the things I think we need to consider too, and maybe looks need to change, is I really don't understand when our hospitals are full in the metro area, how hospitals benefit, and it's a community service, to buy and advertise at the ballpark, for several thousands of dollars, how that helps patient cares. So you have a very loose way to meet your charity needs things. I just think that, I guess what we're looking forward to is, and what I'm hoping is that as we try to be open-minded, we would hope that the hospitals really are, and as I heard, we don't need more surgical centers. I was getting the feeling that maybe, that I know the chairman has asked everybody to come with an open mind to look how we can improve it. It seems like maybe we're going back the old way. And I would hope, since it is the concern of several of us and on here, that y'all would also have an open mind, the thing that you're asking us to do, and that we really keep at the base of this, what's best for the patient. And, that would be our underlying, and that we're certainly, what's best for the patients. They have access and care to good services in our rural areas, and Georgia is rural. So it's not that we're not going to be looking at them, but there are other things that are best for patients. And I hope we'll look at those and have an open mind from everybody.
I think you're right. We agree absolutely in principle on the goal and what we're trying to work toward, which is why we have put so much work into that GHA COM work group. We do not oppose the existence of surgery centers. There is absolutely a place for those. And think that, many communities, if they didn't have those, the hospitals would probably have some volume issues as well. What we have advocated for or are advocating for is to ensure that there's a balance so that we have access again to all services, not just more services. One other thing I do want to address, you had talked about making the hospitals whole. I think you're referencing the new directed payment program through the Department of Community Health. We have been very grateful to the department about that program. We've worked closely with them on implementation, especially for some of the specialty teaching hospitals, things like that. It's been a common misconception that that program makes hospitals whole and gets rid of all uncompensated care. The way that the program works, and there's some information about it in the GHA hospital handbook in the back of this notebook if you'd like to see more. This is a Medicaid payment add-on. So it is an addition to the payments that you're getting from Medicaid, but there is uncompensated care outside of that that is still uncompensated. So it doesn't take care of it all. It takes care of a lot of it. But we have had a lot of questions about how that program works. It is incredibly complicated. We are also right now working with the federal government. They are trying to push some changes to these directed payment programs, some limits perhaps. And so we want to make sure that that program is not in jeopardy, that we can keep it in place, because this is the kind of program that has to be renewed every single calendar year. And so as we're paying for this through the hospital provider tax, we want to make sure that those funds are being utilized for purposes that are helpful to the hospitals and to the community, to other Medicaid providers.
Thank you. I want to just follow up on a little bit of that. We have asked all those that are involved in this issue or have an interest in it to come to us with an open mind and not be, not have been made up. And I hope that we as a committee will have an open mind to all this as well. And I appreciate the work that's gone into this compiling of this notebook and the fact that you and some other groups are having some working groups with your members who are looking at this. And I think I see the needle changing a little bit from some of those who just, their only answer to everything was no. I think they're beginning to look at this in a little different light now. And you're going to say, well, wait a minute, let's really look at this and see if there isn't something that makes sense. Representative Hagan has a question.
Thank you, Mr. Chairman. I'll say the same thing that everyone else has said. Thank you so much for this resource. I do look forward to looking through it over the coming days. There's one section, and if I could switch gears here, that y'all may not have gotten to yet. I don't think we reviewed it, was rural hospitals at risk of closure. So obviously I represent a rural part of the state, so that caught my attention. And then also looking at the map of current services, three of my 6 counties have no hospital. And it's quite a drive for them and for ambulance service to get someone in a critical situation to a hospital that can provide care to them, up to 45 minutes to an hour for some parts of my district to get to care. So I'm looking at this rural hospitals at risk of closure, and I see Georgia has got hospitals at risk of closing. 29% of our rural hospitals fall into that category. And hospitals at immediate risk of closure, we have 10 or 15% of our rural hospitals. I'm wondering if you have a list of where those hospitals are, if you could get that. I know that y'all did not compile this table here, but can we get that information? And also, do you just have anything? What are your thoughts on that and the risk of these hospitals closing in the near future? Thanks.
So this is a publication that comes out at regular intervals. As you noted, it's not something that we put together. The publication itself does not provide the list of the particular hospitals that they have identified, and that's purposeful. Because sometimes when you publicly identify those facilities, it helps to spur the closure or quicken what happens when they may be in the process of trying to implement some things that would prevent that. So we don't typically provide that publicly in terms of who is really in trouble. Part of the reason that we included this particular report, and if you go to this, the Center for Healthcare Quality and Payment Reform website, they actually have a number of different reports similar to this with recommendations and various issues, gets back to our ask that we're looking at this holistically, because there are some good recommendations for how to help shore up these rural facilities that are at risk. And frankly, none of the recommendations from this organization have to do with certificate of need. So it may be that, there are some certificate of need reforms that can help the rural hospitals, but in terms of the most direct impact to ensuring that those facilities stay financially viable, probably doesn't have to do with CON reform.
Thank you, Mr. Chairman. When you were talking about payments and making whole, addressing her, it triggered something. I remember in my days in the industry, disproportionate share, DSH. Are they still monkeying around and using that as a political football? Is that what one of the things you're referring to?
Yes, absolutely. And there are I can't remember off the top of my head when it's currently set to expire this time. But that's something that the federal government has been having to renew periodically to prohibit significant cuts in our dish payments, particularly for the state of Georgia every few years. And that still is on the chopping block and set to expire for the cuts to go into effect. And it will be particularly harmful for our rural hospitals now that we have implemented the directed payment program that we talked about it, because one of the things that new program allows us to do is to move some of those dish funds around to send more of them to the rural hospitals. And so even though the dish payments aren't directly linked to the directed payment program, and whether or not that gets renewed on an annual basis and what happens with the current proposed rule that's out from CMS, here in the state of Georgia, we have linked those two things.
Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. The question I have is, have you guys been in contact with SORH? And what are their recommendations around expanding, and I don't want to get too controversial yet on day one, but expanding healthcare benefits through Medicaid to these areas? Is there a way for us to rightly align our priorities with GHA, SORH, and what Representative Kagan said? What is the trigger point that gets us into a place where we sort of lean into these areas and say, we're here to help for real? What do y'all have recommendations for that? And have y'all been in contact with that office?
So we do have regular contact with the State Office of Rural Health. We have not had specific conversations about Medicaid payments, but the GHA position has and always will be that an insured patient is a healthier patient. And we would like to see those patients having access to some form of insurance so that they seek primary care and they don't wind up in the hospital when they are at their sickest point in time. The vast majority of the conversations at this point that we're having with the State Office of Rural Health have been about access related to trauma care, and specifically access for patients who need to be discharged from one facility and moved to another, perhaps a higher acuity hospital. And how do we make sure that those facilities have resources? The American Emergency Physicians,
American College of Surgeons,
thank you, just recently released a report about the trauma needs for Georgia. And so we are leaning heavily into that to determine what resources might need to be allocated to those rural areas. And so we're happy to share that report with you as well.
This question. Thank you for just mentioning the report, and I've asked if somebody can get us that will tell us the other things that we could do for our rural hospitals. I mean, because one of the things we're having, it takes about 45,000 people to support a full service hospital. And we have so many counties and these smaller hospitals that if you take all the counties around them, they don't come up to 45,000 people. And so, but I think one of the things that we've talked about over the years, and is like somewhere where we have emergency services offered, maybe where they can have they could also have like observation beds, 2 or 3, where if there was somebody they weren't sure that needed to be transported to the bigger hospital, could be under observation. So it's sort of a new idea about hospitals where there is emergency care, but also where you don't automatically where there's some discretion to keep somebody under observation for 24 to 48 hours and then make that decision if they need to go on to a bigger, like a spoke, like you've got a middle part and then you've got spokes or something going out. I think we need to explore that so that we get that care to those tiny rural areas, mainly of older, less economically secure people, that they can get the care they get. And then, of course, there's always the problem with downtown Atlanta and the closing of the wonderful old, once called Georgia Baptist Hospital and the clinic there, and what it's doing to, the lack of care for people in those areas. So we have problems. And so, but thank you for that tidbit of information and it's what we're looking for. And I appreciate that.
I'll add that there is a new federal designation called a rural emergency hospital that some of our member hospitals are looking into, where they would not have inpatient beds, but it does allow for them to meet that need in their community, as you just suggested. I know we have 1, maybe 2 that are already down that path, but it does allow them to kind of reserve resources when those margins are so thin so that they can remain within those communities.
Can they have an observation bed for 24 to 48 or a few beds like that? Or do we need to change the rules? If we need to change the CRN rules so something like that could happen, we need to do that. So there is emergency care.
So right now, we're not aware of any issues standing in the way of the hospitals doing that. We have been working closely with the Department of Community Health, and they've been very good about providing guidance to the hospitals on how to make that happen.
Mr. Raines online with us has a question for you. Scott.
Yeah, thank you, Mr. Chairman. I've had my hand up and down because my colleagues on the panel have asked all the questions that I wanted to ask. But I will, number one, Carrie, ask you if you would first thank you for the clarity around the technical component and the work that is yet to be done there and the resourcing needed. I think that's good for the committee to know. I would ask Anna, you and Carrie and others for that matter, if you would, to please come back and provide more detail and specificity around the DPP program. It's I think there's a misconception of what DPP really is and what it really does, and I think there's an opportunity for us all to learn and better understand what that is. And then I think probably Carrie, this one might land on you. Can you or would you both speak to CON application from out-of-state entities and what we see and are experiencing in Georgia? And then finally, just a question from the standpoint of specialty service clinics or specialty service offerings, regardless of whether they be surgery center or imaging center or the like, is there a way to determine and know what amount of charity care is provided in and within those facilities? And if not, what would your opinion be with regards to better understanding what that would be? Thank you.
I'll address the last question first. Yes, there is information reported about the amount of uncompensated and charity care that some of the specialty providers are doing, and we have that information and can get it to you. I don't have it with me today. On the previous question related to out of state applications. I don't have those numbers. If somebody wanted to come in from out of state and open a facility here in Georgia, whether it's a hospital or an ambulatory surgery center or what have you, they would have to go through the same process that any of the other facilities have to do. And, you know, one of the concerns, frankly, that our work group has expressed relates to border areas of the state where if we make some reforms, there may be unintended consequences in terms of the out-of-state providers who are based in another state and who fully have their operations in another state, putting out these little fingers along the border to try to sort of snag those patients away into the state next door. We did have an issue a couple of years ago where we had out-of-state providers opposing and challenging applications of Georgia providers. And the department was able to update its regulations to prohibit that. So now you actually have to be located and providing services in the state of Georgia in order to do that, to make things a little bit more fair and make sure that we're really keeping the Georgia patients in mind. To the extent that applications are getting opposed, we want to make sure that it's Georgia patients that are benefiting from that and not out-of-state patients.
And just a follow-up, just if you would, in our subsequent meetings that we have coming up at some point, let's come back to DPP, please. I think, again, it's complex, it's new, and it's new in many areas, especially within the state of Georgia. I think we'd benefit from understanding that in the most comprehensive way. Thank you.
Yes, happy to do that.
Thank you, Scott. Thank you for y'all's presentation. I'm sure that we're going to be having much more conversation as we move forward, but thank you for the information you brought us, and we appreciate you being here today. Thank you. Next, we're going to hear from Jamie Kavanaugh with Institute of Justice.
Right. Good morning, Chair Parrish, members of the committee. Thanks for inviting me to be here today. I'm an attorney at the Institute for Justice. Institute for Justice is a national nonprofit. We've been working to reform and repeal certificate of need laws for over a decade. We do that through litigation and through legislative work. We put out policy briefs and papers and studies as well. So we look at this problem from a lot of different angles. And I wanted to start by addressing a couple of the questions that came up, and then I'll move into kind of the prepared remarks that I have. But first of all, there is an existing study from the Georgia Public Policy Foundation. I don't know if Chris Dunson is here or not, but okay. You will all get copies of that. And it has a review of 6 years of certificate of need applications in Georgia. This goes to a lot of the questions you were asking about applications. So in reviewing those applications, there were 379 applications over 6 years. And the authors found that opposition from a direct competitor added 520 days to the time to a decision. Any opposition from an additional party added on average another 129 days of waiting time for a decision. And regarding the appeals, the process, you can't have multiple parties appealing the same decision at different times. It wouldn't be that you would get to the end of a whole entire appeal process, go all the way to the Supreme Court of Georgia, and be done with that, and then start over with a brand new appeal. That would never happen. But what happens is you get your decision from the department, you have your one administrative appeal, then it goes to Superior Court in the county that you're located in. Then you go to the Court of Appeals, and then you go to the Supreme Court of Georgia. And either from the Court of Appeals or the Supreme Court, you're often sent back to the county court to redo something. or sent back to the agency to redo something. So I looked this morning to see what appeals were still pending on applications right now. And I saw 6 appeals that have been pending still listed on the department's website. And one of those was for an application that started in 2018, and it's still going on, it's still in the court system. So, you know, that's 5+ years, maybe 6 years. And then one was from an application that was filed in 2019. And the other ones were later times. But so, you know, that gives you an idea of what some people are facing. And Representative Cooper, you pointed out how much money healthcare facilities are spending on this litigation, and the state has costs as well. The state is involved in this process as well. And it really is, I think, a bigger deterrent. I think members of the committee have acknowledged this, but smaller providers, people who might have innovative ideas, who might want to do something differently, they cannot compete with bigger healthcare providers that can spend the time and the money to go through this whole litigation process. And someone asked about how do we quantify who's walking away and giving up without even filing a certificate of need application. And that's something I think about a lot. And I reach out to a lot of providers to try and learn about that issue. And I've been talking to some surgeons lately who have told me stories about wanting to open ambulatory surgical centers. And really, you know, their advice when they go and talk to local attorneys is you don't want to go down this path. You're not going to be successful. So it's really disheartening when they want to, you know, provide services that they see every single day are needed. And regarding an issue that was just brought up about patients leaving for border areas with other states that don't have certificate of need. I mean, we see now South Carolina and Florida hardly have any certificate of need left. So that's going to start happening. That probably already has started happening. The state of Oklahoma doesn't have certificate of need for surgery centers or hospitals. It only has a couple certificate of need laws. And we see there that they have a very successful model of ambulatory surgical centers, and insurance companies around the nation are sending their patients to Oklahoma to have their surgeries done, orthopedic surgeries done there, because it's so much cheaper than hospitals. So if we're talking about healthcare dollars leaving the state of Georgia, that's happening all over the place because certificate of need doesn't help keep prices competitive and doesn't keep patients in the state. Okay, so I wanted to talk about access today. And one thing I wanted to mention, you already know about the federal inducement to start the certificate of need programs in many states, but I wanted to remind you all that the government reimbursement system was different in the 1970s and 80s when the federal government passed the law to require states to enact certificate of need programs. At the time, the government was using a cost plus reimbursement system, and healthcare facilities were being reimbursed for their full costs of providing services. And we know that's not the case today. That's why we have these problems with cross-subsidization and stuff like that. But at the time, in the 70s, government thought hospitals were growing too quickly because there wasn't really any risk involved when they expanded services and added beds, because they knew that they would be reimbursed to their full expenses for anyone that they served. So the intention behind passing certificate of need laws was to limit hospitals and to limit hospital beds, to limit the growth of hospitals, to limit spending. So the idea that certificate of need increases access to care is contrary to its very premise for why it was adopted. And in fact, since reimbursements have changed since then, you know, we also don't have the underlying reason anymore for passing certificate of need in the first place. At the time, so Congress repealed that mandate in 1986. In 1988, one of Georgia's congressional representatives, Representative James Rowland, was talking about the problems he saw with the certificate of need program in Putnam County. He called them insensitive to the true needs of the community, and he said the effects on healthcare costs were dubious at best. His example was that there was a local hospital in Putnam County that had been there for 20 years. It was a 50-bed hospital. It wanted to do some renovations. It was not going to expand. It didn't seek to add services or beds, but when it asked the con agency for a con just to do renovations, the agency said it would only grant the con if the hospital removed 10 beds. And of course, the hospital had several logical reasons for why that would be expensive and inefficient. The population in the county was growing. The hospital had a nursing program. They would have to admit fewer students to the nursing program if they did that. And reducing the number of beds by 10 wouldn't decrease healthcare costs at all. And in the future, who knows if they would ever even be allowed to add those beds back, but the agency didn't accept any of those answers and wanted the hospital to decrease the beds to be closer in line with the regional quota. And that's when we're talking about these need formulas and kind of the numbers that we come up with for the need for different regions. That at that time, the agency was sticking very closely to kind of what the need predictions were. And I think that is often still a problem. We heard that maybe the need formulas haven't been updated in a long time. And I wanted to give an example from home health agencies. There, the formula looks at the population, and then it also looks at how many patients have used home health care over the last year. And it uses that data to predict how many patients will need home health care in the upcoming 2 years. But it can't take into account the people who aren't already getting enough care. I think this was alluded to already, but the users who aren't already accessing services aren't anywhere built into that formula to begin with. So when they predict new need, they're left out of that formula. How do we know who's not getting who's not getting services and who actually needs care? So it's good that the department mentioned you can do an application, I guess, and show other metrics for need, but I think that's pretty rare. I think, as the department mentioned, there's batching cycles, and that's how entities find out if the department is even accepting applications for various facilities and services. And so I think when the need formula doesn't show need for different regions, that most people don't try to apply for those services. In Georgia, the need formula has to show a need of 500 patients for a new home health agency just to be allowed to apply for a certificate of need. But if you are an existing home health agency, if the need reaches 250 patients, you can apply to expand. So, this is another maybe anti-competitive consequence that existing agencies can expand before the need ever reaches 500, and in theory could prevent new agencies from ever opening, especially agencies that might want to do something different or cater to a certain population or something like that. And the most recent forecast shows that only 3 out of Georgia's 12 regions for home health agencies need care, but home health is something that is a lower cost alternative to inpatient care. Most people would prefer care in their home if that's an option. As the population ages, we would really expect this to be something that we would need more of. So it's fairly surprising that only 3 of the 12 regions are projected as needing more care. The other thing I wanted to talk about is access to rural healthcare. That is such an important topic, and we all want to make sure that the rural hospitals can thrive. And what the data shows us is that states without certificate of need have more rural hospitals. They have more ambulatory surgical facilities in rural areas, and that's per capita. So one thing I wanted to mention about the studies is that I don't know if you know economists, but they're very cautious people. So when they do their studies, it isn't really this apples and oranges comparison. They know which states have, hospital cons and which states have nursing home cons. They're not just saying, oh, this is a con state, South Carolina and Florida and Georgia, and you're all the same. They know which cons they're comparing, and they control for things like population, geography, age. health status, payment method. They do all those things in their studies, and you can read them and see, they list exactly what they do in their studies. So these comparisons, while sure, maybe there's still things that they're missing and maybe they're not 100% perfect, they do try very hard to make a fair comparison between different states. So, if the studies are telling us there are more rural hospitals and more urban hospitals, but specifically they looked at rural hospitals, if there are more rural hospitals and more rural ambulatory surgical facilities in states without certificate of need laws, that kind of dispels the argument about the cross subsidies, right? Because if there's more hospitals and more surgery centers, then everyone's doing better with competition. It's not the argument that the surgery centers open and all the profitable patients leave and then the hospitals shut their doors. If that were the case, then we would see a spike maybe in surgery centers and we would see lower numbers in hospitals, but that hasn't happened. 40% of the nation lives in a state with either one con law or zero con laws. The ones that have one are usually just for nursing homes. So when we're talking about hospitals, that's 40% of the nation that we can get good data from and see what happens. And we don't see this parade of horribles happening. In fact, Georgia has had 10 rural hospital closures since 2005, sadly, and that's with certificate of need laws in place. And there are several states that don't have con programs for hospitals that have had 0 rural hospital closures since 2005. And those are Colorado, Montana, Oregon, Utah, and Wyoming. And obviously several of those states are very rural as well, but they have had 0 rural hospital closures. Other states that have certificate of need laws have recognized that the certificate of need laws are not helping their rural facilities, so they've exempted the rural hospitals and rural facilities from their certificate of need laws. They've kept con in place, but they've made exemptions specifically for rural areas. So that's Alabama, Kentucky, Oregon, Tennessee, and Washington. So, there's never a single reason that a rural hospital would close, and there are lots of other discussions we should be having about how to help those hospitals, but certificate of need isn't the silver bullet, unfortunately, that can save our rural hospitals. And several other federal agencies agree about the problems with certificate of need laws. The Federal Trade Commission and the Antitrust Division of the Department of Justice have been consistent across Republican and Democratic administrations since the 80s, saying that states should repeal these laws. The Department of Health and Human Services, the Department of the Treasury, and the Department of Labor have also produced reports agreeing. And my final point I want to make today is that the pandemic kind of showed us the dangers of using con to limit access to healthcare. Georgia, like many other states, was forced to quickly kind of walk back some of its con regulations at the beginning of the pandemic. And, if loosening con restrictions can work then, it can work anytime. But the effects of, of con on access, unfortunately, weren't undone kind of by these quick actions to suspend the con regulations. So the research actually shows that hospitals in states with con laws were 27% more likely to run out of hospital beds than in states without con laws. And there was no difference between the states with con laws that relaxed their requirements and the ones that didn't. So that just shows us this, artificial cap we're putting on the number of hospitals and the number of beds can have very serious consequences. And it's not something we can quickly undo, unfortunately. So when the country needed access to more care, we didn't say we need more con laws. We said we need fewer con laws. So I'm happy to answer any questions. I look forward to continuing to work with the committee and answering questions now or as the process moves forward.
Thank you. We do have a question. Leader Bailey.
Thank you, Mr. Chairman. So just sort of by the numbers, we have 53 counties that have no hospitals. Takes 45,000 people to make a hospital whole, right? We have 10 counties, we have 10 hospitals right now that are in danger of closing. My question is fairly direct, and that is, of the states that you mentioned that don't have CON laws,
Mhm.
how many of those states have not expanded Medicaid?
That's a good question. I do have that written down. I will email it to you as soon as we get done because I've gotten that question before. I'll mention that North Carolina's recent reforms were tied to Medicaid expansion. So that's that issue about the certain things come online 2 years after certain payments start and 3 years after payments start. The bills were tied together in that way. So that's something that some states have looked at. I'm not endorsing that one way or the other, but I'm just giving you the information that has happened. Most of the states have expanded Medicaid.
I thank you for your presentation, and I want to especially thank you for bringing up the home health agencies. Georgia is a Georgia is a aging state, and this is a special interest of mine, and how our rules can, stop innovation and new programs. We have a group that it's state-based where the elderly come together, a group of elderly, and every year they vote on their top 3 issues they want to bring before the legislature. And last year, they wanted to bring a bill that would have looked at and new innovative ways of delivering long-term health care. And a couple of the board members worked and were very involved with one of our biggest providers of nursing homes. And they stopped it cold turkey of even exploring what might be a better way for them to, even they could present and do a different way of dealing with our aging. So our CON laws can really stop innovation. And it's sad that it does, but it can.
Well, just a couple of quick points. I know the GHA had a form in here that said Medicare reimburses for every dollar a hospital spends providing care, they reimburse 84 cents. And I know Medicaid is much less. So I guess that's maybe one reason we don't see some salvation of rural hospitals, because somebody expanded Medicaid. If for every dollar you spend, you get 75 cents back. That's certainly not, especially if it causes patients, unlike the Georgia plan, if it causes patients to shift off of a Blue Cross plan on the exchange to Medicaid rates.
Mm-hmm.
So I know that's a problem. One of my questions regards this, some of the states that have exempted rural areas from CON and the effort to push theoretically because of the lower barrier to entry, whether it's legal cost or delays or uncertainty that come with a certificate of need applications and appeals. Have we seen in some of the states, you mentioned Kentucky, Oregon, Tennessee, I don't know if they've been in effect long enough. Tennessee obviously is pretty close to us with 95 counties compared to our 159, but it'd be interesting. I know they probably go just across the border to get into a rural county, but at least it's pushing it to rural areas. I'm wondering if anybody's had success improving or decreasing rural travel times to good healthcare, new hospital healthcare, modern hospital healthcare, by allowing CON in the rural areas and keeping it in the urban areas. I guess that's what I'm reading. Is that correct? Or have they been able to push new facilities into rural areas?
That's a great question. I don't know the answer about new facilities opening versus just the existing facilities not closing. Oregon, for instance, I do know that they've had the exemption for rural hospitals since before the University of North Carolina started tracking this data. So they've had it the whole time, and they've had 0 rural hospital closures since 2005. That's when the University of North Carolina started tracking this information. So that's one place where it may have had a positive effect. Tennessee's exemption is a little bit more narrow, I think, but it applies to critical access hospitals. So I think you have to meet that designation to get the exemption in Tennessee.
Okay.
Yeah.
It's pretty hard to run a 25-bed full service medical center in 2023.
Yeah, absolutely. I agree.
Thank you.
Just a quick follow-up question. You know, my dear friend, Dr. Newton, we always get in these debates, but here's a question I have. You have 53 of these areas in Georgia that don't have hospitals are located in less developed census tracts. So people don't have a lot of means. So what I really like to understand is if you don't expand Medicaid into these areas, what is the revenue stream that these folk, whether it's certificate of need or not, but the providers get from places where people don't have a lot of means? Like, what is a revenue stream that props these places up is really what I'm looking for. Where is the alternative revenue stream that comes into helping these areas get the services that they need at that time, the capital outlay for projects or whatever it is? But
Right.
really, what is the revenue capital stack that you put together to make these things work?
I don't know the exact answer to that question. I can see if there's more studies on that and provide you with that. I think that a lot of the information we're looking at is around trying to keep the existing facilities open versus I don't know how many new facilities are opening in rural areas. That's a challenge everywhere in the country. It's not unique to Georgia, unfortunately. So it's something everyone's thinking about, you know, and like we're talking about the spoke and the wheel. That's one thing that bigger healthcare organizations are doing.
Thank you very much for your presentation. We appreciate you being here today.
Of course, thank you.
This ends our agenda that we had lined up for today, but we also had an opportunity for anyone who wanted to speak, and we've got a few minutes, and we have two folks that have signed up saying they would like to speak for a minute. So I'm going to ask Brian Allen, Libertarian Party of Georgia, to come forward and in a few minutes make his presentation at the podium there, or come to the table. That'd be fine, right here in the middle. If you would, please identify yourself and begin.
Hi, yeah, my name is Brian Allen. I'm a Georgia resident, and I'm not a lawyer or any sort of expert on the effects of certificate of need laws on health outcomes for people of Georgia. I'll leave that sort of discussion to other speakers who've already gone. But what I would like to discuss is how certificate of need laws enable cartelization in the state of Georgia. In order to raise prices and achieve greater than normal profits, a firm needs to decrease supply. But a single firm attempting this is just self-destructive, as competitors will rush in to meet demand. Firms across the entire industry need to agree to decrease supply, and when they do, a cartel is formed. Unfortunately for them, but fortunately for us, the people, cartels are inherently unstable in a free market, inevitably collapsing from internal and external pressures. The only way to have a cartel that lasts is with anti-competitive regulation from the government. That is exactly what certificate of need laws do, serving to restrict supply so that a cartel may be sustained, as new competition must first be approved. The firms that benefit from being in a cartel will come up with all sorts of reasons for why there needs to be a restriction on competition, why their particular industry is special and needs these regulations. They can sound plausible, and the people saying them might even believe them. But at the end of the day, it is always true that cartels benefit special interests at the expense of the general welfare, with any valid concerns basically always stemming from other government regulations. The unfortunate reality of politics is that the advocates of special interests have an advantage over the defenders of the general welfare, but you have the opportunity to do the right thing for the people of Georgia. Other states have already shown that can be done, and I hope with your help, Georgia can eliminate these certificate of need laws. Thank you for your time and attention.
Thank you. Any questions or comments? Thank you very much. The last person we'll hear from today, Victor Moldovan, Holland and Knight. Yeah, please.
So I've been coming down here, as many of you may know, a long time talking about certificate of need. I typically represent physician-affiliated groups, physician-owned surgery centers, physicians just in their general practice. And generally, the people that I represent in Georgia like more flexibility. Physicians need the opportunity to increase if they want to put a clinic in a rural area, to have the opportunity to have ancillary income. One of the things that they do to do that is to have surgery centers. They're allowed to do that in a limited capacity in Georgia now under an exemption. That exemption means that only their practice, just their own single group. So you might have two doctors who do the same practice in a small little town, but unless they're in the same group, they have to both own their own little surgery centers, which economically doesn't work. So we generally support the idea, and we appreciate the committee and the speaker and Mr. Chairman, you taking the time to look at this issue. The prior speaker from the Institute of Justice actually noted some things that I think are important again to restate. The law that was adopted back in 1978 or 79 as a result of the federal mandate. That federal mandate was only because the federal government was paying cost, meaning if I wanted to build a hospital, the federal government would pay for it. Even home health back then was paid for by the federal, it was cost. You filed a cost report, and if it cost $1 million, well, that's what you got paid. That has completely changed, right? The landscape for reimbursement, the landscape for how care is provided. Back in 1979, could you imagine doing an outpatient procedure on a spine? No, that's being done today. You're doing hip replacements outpatient today in one day, maybe a day and a half. So the idea that somehow we're dealing with a law that was adopted when reimbursement was entirely different, when the kind of care was entirely different, where you got the services provided was entirely different. Things have changed since 1979, as you all know. We're talking 40, 50 years ago. So the law that's in place today, yes, there have been some changes. We support more changes, more reform. There has to be a way to manage, any concerns you might have about, access and need without really blocking competition. Because certificate of need, that's what it is. It basically prohibits new or expanded services unless the state says they can do that. And those ability to expand or get new are limited by the rules that are in place today. Some of the rules, frankly, the need methodology have been in place for years. They've not changed. They need to change. If you're going to keep CON, those need to change. I think the state speaker said that there is batching cycle, and the batching cycle means, twice a year, the government says, yes, you can file for a certificate of need. So a surgery center that wants a CON, you got to wait for the state to tell you. But even under that scenario, the state can decide not to accept applications. So my surgery center clients have not been allowed to file any surgery center applications for 2 years because the state's determined there's not only not need, we're not going to allow you to apply for an exception. So effectively, I can't even file. And it's not a matter of getting denied or approved. I can't even file. We don't think that's correct or right. We don't think that they should be able to do that. If I can show and a client can show, yes, I can build something that makes sense financially, it's accessible, I should be allowed to ask that question. So I guess overall, I look forward to the debate. I'll be around, obviously working on this with the committee if you're willing to let me do that over the next few months. But we support looking really strongly at the opportunity to reform this. I do want to point out that some of the concerns about rural areas, they're not going to be fixed by CON. CON is not stabilized rural healthcare. It will not save it in the future. There needs to be a mechanism in place, not CON, that addresses cost reimbursement, whether it's some sort of stabilization unit, where that money comes from that. And I don't know that it's Medicaid expansion or not, but certificate of need really is not going to fix that or address that any which way. In fact, it hasn't helped so far. What you want to do is open that up to hopefully attract more investment, more opportunities, and that might take some state or private public partnerships to get that done. But CON is not the answer. So those were my comments for today. I just want to say thank you again for letting me speak. Thank you.
Thank you. Any comments or questions from the members? Thank you for being here today. We appreciate your comments, and I understand some of your concerns. As I mentioned earlier, we're glad to listen to those, but what we'd really like to have from you would be some solutions.
Sure.
So if you've got some solutions that you think would make a difference, we'd appreciate that. Okay?
Thank you, sir.
Good. Any other comments or from the committee? Thank you all for coming, and thank you for our members who joined us over the internet today. We appreciate you being here. Thank you in the audience for coming and your interest. And obviously, I think you can see that this is a complex issue and it's going to be talked about quite a bit. So we'd invite you all to join us August the 1st in Augusta. We're going to have the second of our 4 meetings there. And with that said, we'll adjourn today. Thank you very much.
Thank you for your leadership, Mr. Chairman.